have a definitely the physical distress will be increased. So the assessment of the psychosocial issues is one of the important aspects. So today we have Ms. Deepa who's with us, who is a senior medical social welfare officer here. She has 9 years of experience in various settings. She did her specialization in mass medical and psychiatry from Bharatdasan University, and she had worked in Kottayam. And also she had worked as a psychosocial counselor in Alapura, one of the NGO there. And also she had worked in Delhi as a project coordinator, as a community field uh, there. So she is a well-versed person in this field. Welcome and over to you, Deepa.
Thank you, ma'am. Thank you. So, today we are going to talk about the psychosocial aspects of care. So, why we need or what is psychosocial care and aspects in a palliative care setting? Is it what is the importance of psychosocial care? It's not only psychosocial care; it is from the aspect of social, economical, psychological, emotional, spiritual, and the total pain from all these aspects. So we are going to talk about it. We have a PPT, and uh, if you have any doubt in between, you can put the doubts in the chat box, or we can have a discussion later after the class. So, in today's session, we will have the total pain concept, social diagnosis, assessment in the all aspect, and the genogram, echo map, and plan of care. So, we are going to talk about these aspects. So, as a whole, I think you all are aware that according to WHO, what is the definition of a palliative care? As the definition, it is an approach that improves the quality of life. So we are looking for the quality of life of the patient and their family. It includes their problems that associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems. That other problems could be physical, psychosocial, and spiritual. It's a case study as given. I can come to that later. This has been given for the detailed discussion for genogram. So we can come to that later. But keep it in mind that this type of a person is coming to our palliative care service for a service, for taking a service. A 56-year-old lady, Mrs. A, has been diagnosed with a severe breast in 2016. She had undergone mastectomy, it's a breast tissue removal surgery, and she was referred for pain management. So she is coming to the palliative care service. She looked very anxious and had no idea about palliative care. Comorbidities. What are all the comorbidities she has? She has diabetics since 12 years. She has coronary artery disease, and she had a fracture due to a fall in 2019. She is a widow, and her children are having a hostile relationship with her. Lives alone in her house. So please keep this in mind, and we'll go to this case later. This kind of cases are coming to us. So, as a palliative care service provider, what are we going to do with her? What are all the assessment we are going to do with this person? We'll go to that step by step. This is why is psychosocial care important in palliative care? We saw a person who has a life-limiting or life-threatening illness. And the awareness of approaching death causes unique stresses and challenges, definitely. A person who came to know that she has a life-threatening disease, she will be having so many questions in her mind, whether to stuck or whether to go, whether to have treatment, or if she is the only one earning member in the family, what will be the future of the family? And there will be dependents, their children, her husband, her parents. There are so many people that will be depending on her, uh, on her as a person. So, what are all the stresses and challenges she's going to have? So, these are the things that will be coming firstly into her mind when she is got diagnosed with an illness. As I said, a serious illness disrupts the individual's thoughts and feelings, relationships, social and spiritual supports, financial stability, and spirituality. Of course, a serious illness, definitely, if we have a serious illness, we will be having different type of thoughts. It could be suicidal, it could be like how to move, a stuck or a hopeless feeling, hopeless thought, or suicidal, because I don't have to, I don't want to live in that family, because I could be, can be a burden for the family. So why should I live? And her feelings, she might cry, she might she has lost hope in the future. Then the relationships would be definitely affected. Her children might not be able to look after her. They might not be financially well in, so, to look after her mother. Or lots of relationship issues might happen. With her husband, sexual issues might happen. Because of her illness, she won't be able to cook for her family. She won't be able to do the daily activities in the family. What are all the routine that we all know, that what are all the activities that might be affected with an absence of a person, the important person in a family? As like the social aspects, mostly we depend on the neighbors, the work setting, or the people near to us, could be friends. So if they find it as there is no need of contacting that particular person because she has an illness, so that kind of thought that make her isolated from all these groups. Then spiritual supports is, it's not only a belief in God. It could be like her one of the recreational activity. It could be one of her hobby. So in spiritual support, these kind of activities, leisure activities, or going to a prayer, going to a temple, or going to a beach, or going for a cycling, swimming, all those activities that make us relieved from the stress, could be the spiritual support. So when she diagnosed with a life-threatening illness, she is limited to all this. So that is a spiritual supports. Then the financial stability. Of course, we know that if we have a illness, we have to spend lots and lots for treatment, to travel, for seeking other support, like some bystanders, or somebody that we want to hire. So in many ways, we want to spend a lot. So here is the total pain comes from these aspects. These are the 4 aspects that cause a total pain in the family or to the patient. The physical pain could be, we know that physical pain could be anything that limits us, or that affects our health. That is purely related to the disease or the illness. She might not be able to walk. She might get bedbound. She may have to use wheelchair. So these aspects limiting her to access something that she wants. And pain, definitely, we know that the pain that a person carries when I mean earlier to the diagnosis, that goes worsen day by day. That pain and related to that she might get wounds, she might have to use catheterization, she might have to be in right tube. So day by day she is dependent, she is getting physically worsened. So that is a major part that causes total pain. It's not only to the patient, it could also be to the family, because family has to have more and more supports in between. They have to arrange a wheelchair or a airbud, or likewise they have to spend a lot for the patient, and there might not be anyone to carry her to one place to another, especially to the toilet. So the family is also getting affected with that. Breadwinner may not be able to go out because he has to take care of his wife. So he may not be able to go out for anything. Her children, they might be getting good education from her mother, but after falling ill, she will not be able to assist her children to teach them or to motivate them or to mentor them. So there are so many aspects if a person get physically ill. Then comes the psychological part. In psychological part, we could see that emotional imbalances between the family or the psychological distress after knowing an illness is affecting the complete bonding of that family. She might be crying, she might be having anxiety, she might be having some worries about her future or about her children's future or her husband's future. So there are so many questions, there are so many psychological distress coming through her mind. And she might develop anxiety, she might, due to that, she might develop obesity, or she might become nauseated, she might become emaciated. So there are so many issues that causes due to psychological distress. And her psychological status is also affecting the family. Her illness is also affecting the family, that my dear one is getting has a life threatening disease, so how will I support her? If it is from a poor income generating family, then they'll definitely have thoughts that whether I could give a good treatment for her, I am good for nothing for her because I don't have enough income to or money to treat her. So that kind of worthless, hopeless feelings and support to parents, to her children, as being a mother or being a daughter, she may not be able to take up her responsibilities or roles and responsibilities that is related to a person. So she may not, she is limited from all these aspects. So these facts definitely will cause a psychological distress in her and definitely towards her family. Then the socio-economic. In socio-economic, we have social pain and the economic pain. Economic pain, as we know, that definitely the financial constraints. We might be having people in a high income family, but it doesn't mean that they have this high income continuously. For all the treatments and for all the investigations, for all the discussions or clinical supervisions, or for special needs, family has to spend a lot and lot for that. And they might have to take loans, they might have to depend on financials, they'll be having debts that after falling persons fall, they may not be able to complete that debts. So that financiers that make problem towards the family. So these financial constraints that will affect the family until they get a good supporting system. As social factor, we know that if a person is ill, the friend circle or the neighbors, they might hesitate to talk to that person or to that family. It could be either like because of a financial thought that they might ask for money, or it could be like uh, a person's illness can might make them also ill. It's like communicable. Their thought might be like it is a communicable disease, so I may get affected because of that. So it is being good to uh, make a step away from the family. So social isolation in many aspects due to various concerns, the family or that patient might get isolated from the society. And as I said, the spiritual. Of course, we all have a belief that we'll move on. We'll have a supporting system. With these systems, we'll move on, and a belief in God. Or as I said, I could do gardening, or I could do a drawing to relax my mind. But after getting an illness, I may not be able to pursue all these things. Spiritual aspect always we consider it as something that depends to God, that depends to prayer, that depends to temples. So people might think that I could go to a church and that is the only spiritual activity I have. But this is not the only spiritual activity we have. We have so many other activities that uh, make us stand, and they make us relax. They make us to relax. So these activities get affected when we have a life-threatening illness. It is not only to the patient, the family. They might not be able to go out for a shopping as a group. They might not be able to go. They might not be able to go for a trip that they usually used to go. So these all things, these all spiritual activities, that the limitation of all these things that cause a total pain. So these are the four aspects. According to that, we'll have certain assessments as well. So when a person affected with a life-threatening illness and they have to have a palliative care service during the diagnosis itself, they'll come to us. They'll come, and from the point of time, we'll have certain kind of assessments. From the beginning onwards, we'll have these assessments. We'll have a set of assessments in these four aspects. Of course, we know that an assessment could be an exploration process of gathering information about the person. The selection of goals and interventions depends largely on what is being assessed. Of course, we'll have a various set of information that makes us to move with the person, with the patient, to provide them the better care. The selection of goals are depend on these exploration process. So assessment process will be coming in detail. The main aim of assessment is to identify problem areas which result from illness and may influence the well-being of patients and their families. This is the physical part. In the physical part, we'll assess that where do they have pain, or when did the history of their illness. investigations, lab tests, reports, and previous discussions with the doctor. All those aspects, physical aspects that is affecting the well-being of a patient is gathered in the physical assessment. This collection of information and identifying and honoring the strengths, resources, and needs. This comes in the resources part, whether to strengthen the support or what are all the support system they have around them, or what are all the resources that could be identified to utilize better care for the person and their needs. What are the strengths they have? So identifying and honoring the strengths, resources, and needs. These parts are also involved in assessment. This is an ongoing process, of course. Assessment, the first time itself, we might have a group of families, a group of family members coming for a palliative care service in the beginning. But later on, we can see that only her children might be coming with her, or her parents might be accompanying her, or later only her husband will be coming with her. So maybe in future she might be alone. So assessment is an ongoing process. First, we have a total number of family together, and later at the end, she has none. And her financial status, if we assess her financial status, it might be well, she might be above poverty line, but later coming to the end, she might be belonging to the BPL category, that is below poverty level category. So we have some certain categorization of poverty level in India, or that is differentiated from Kerala or with other states. So we have this APL and BPL category. Among that, we have 4 other criteria. So when during the first assessment, if the person belongs to an APL category, then later we might be realizing that she is falling to a BPL category. So that's why I said assessment is an ongoing process. Her psychological status. She might be in distress in the beginning, and it might get worsened later. Or maybe after a good palliative care service or a good treatment, her status might get developed. As the psychosocial needs of patients and family caregivers often change over the course of illness. So during the course of illness, disease, these status, physical, psychological, economical, emotional, or spiritual status might get changed. So assessment is an ongoing process. We need purposeful observations and purposeful conversation in between. Then only we could deeply understand a patient and her family. These are certain techniques. We could see a path, we could see a falling house. Why we have these pictures is we go for home visits. We might get information collected from the patient and from the caregiver. And apart from that, only this patient and caregiver will be coming to our center. But after that, if we need more information about the person, we can go to the friends, relatives, neighbors. And during these home visits, we could collect more details. See the situation of a family. What is their path that directs us towards the house? They don't have proper traveling system. Even a two-wheeler cannot reach to her family, her house. And this is the situation of her house. She has only a single room in that she has to cook, she has to lie, she has to have everything in that single room. And if it is raining, definitely she cannot survive in this situation. So when we go for home visits, we can collect all this information, and this is something that for a deep assessment that we can use. If you want to, if we want to continue with the support for that family, we should have these kind of home visits. Then only we will realize, and then only we can make a report on the person, and we can seek for help. Coming to the points that are coming under an assessment are patient overview. Patient overviews, as we know that when a person comes, we'll ask their name, their age, history of illness. All those details we will ask. Who are all there in the family? All these aspects can be explored in a patient overview assessment. And then comes the insight. Insight can be asked to caregiver as well as the patient. Why is it needed? We need to have insight to know that whether they know about the illness or not. The family, they might not be able to know about her illness. So for knowing these aspects, we have this insight code. Then the family overview. Family overview is used to collect the details of the members in the family. Then coming to socioeconomic, psychological, and spiritual. I'll go one by one after this. In patient overview, as I said, name, age, gender, their diagnosis, the history of illness, all these details are collected. And then the insight. Insight is to understand what the patient or the family know about their illness, their diagnosis, their prognosis, and definitely on palliative care as well. If we ask a patient that what is the expectation of a palliative care service, what are you expecting from a palliative care service, they'll definitely say, as cancer patients provided with catheterization or with the catheterization changing or with the wound management. They have no idea about palliative care in detail. They just know that it is only for cancer patients. There are many persons, they just know that it is only for cancer patients. And it is only related to catheterization. And it is only related to some kind of medicines. So this is the awareness about palliative care in most of the population. But this is important for us to know because they should be explained well about palliative care. And before explaining, we must know that what is their idea about palliative care. And awareness on illness. What is the diagnosis? What are they diagnosed with? Whether the patient is known about the diagnosis or we don't have to speak about it. What is the status? It is important to treat that patient because the family might not be able to convey the message to that person that she is ill. She has this life-threatening illness. So they are worried that if she knows that diagnosis, she might commit suicide or she might go hopeless or it might affect in many ways. So they might not want to convey the diagnosis towards in the patient. So we'll use a term that collusion, whether the collusion is positive or not, or negative, whether we want to discuss it with the person or not. So when we speak about it with the family, they'll say that please do not talk about it. So we'll mark it as pollution positive. When the doctor knows that he doesn't want to open anything to about the treatment or about the diagnosis with the patient. And if the family, we can see sometimes we can see that patient might be strong enough than the family member, and he might not want the family members to know about the disease or about the prognosis. Even if they know the diagnosis, she might not want to convey the prognosis. So we'll mark all these things in the inside column. And at times, in a certain time of intervention, we have to have an explanation about her prognosis. And with the family's support, with the family's understanding, we'll make them understand that it is necessary because the person has these kind of expectations, and she is expecting a lot in her future, and she cannot do that, and she has lots of activities to do. She has to celebrate her birthday, she has to celebrate her wedding anniversary. So if the patient has these kind of expectations towards, then a point of time doctors or nurses might feel that like we have to break the collusion. We have to tell the patient that she is having this kind of, she's in this stage and she cannot survive more, and she has to know that this is the life she has. Then we need to have a psychological intervention, deep sessions with the family, and later we can have the sessions with the patient as well, or whoever that colluded. So this is the part of insight. Then comes to family overview. We'll have a detailed genogram. As we all know that we have certain features that certain pictures that we use to have in our genogram to represent the family members in the family. We can come to that. In family overview, we'll also note that who is the primary caregiver for the family and the support system, who are all there to support them, whether it is her friends, whether it is her neighbors, whether it is a school where her children studies, and the structure of family, what kind of structure it is, nature of relationship, what kind of bonding they have, whether they have a stressful relationship, whether they have a good bonding with each other. So for knowing all these things, we have family overview. We'll have a genogram in detail. These are the basic symbols that we use to represent male and female person in the family. I think this is a pattern that all might be aware of. The square box we use for male person, and circle of course used for female person. And for unknown gender, we can have a question mark. And this relationship, the first one, a single line shows married couple. And for unmarried people, we'll have a dotted line. We can come to that later. And a strike between the relationship shows they are separated. These two strikes shows they are divorced that is legally separated. So first one is married, and a strike between the line shows they are separated, and two lines between the person shows they are divorced or legally separated. Children and birth symbols. First one, we can see that the biological child, the child, and adopted child is, we can have these kind of dot lines. We can use different colors to represent this. We can have green, yellow, green, blue, and red and black pens to represent these structure. And foster child, person in pregnancy, a miscarriage, abortion, male, that is stillbirth, female and stillbirth. So this is the symbols that we use to represent children. This is again fraternal twins and identical twins, triplets with a female that is still to birth. So this is the symbol that we use for showing twins or triplets or more. Here comes the emotional relationships. First one is a plain and which is normal relationship. When we define it, this is not very useful except to highlight a normal relationship among massive dysfunctional relationships. The line is colored in gray. We can use, as I said, we can use gray color, and for friendship we can use green, red. These colors indicate if this family structure itself indicate what are all the supporting system in the family, what are all the strainful situation in the family. These colors, of course, we know that the first thing that strikes when we saw a picture might be these colors. So that's why we use various colors to represent the structure. And first is a normal relationship. And the second one is friendship, a close friendship that shows in the dotted line. Two dotted lines, which shows the close relationship. It could be friendship, or it could be within the children, or towards other family member. It can use in many relationships. And then comes the intimacy, very close relationship. There is no dots in between. They are very close. They are very intimate. And then comes the hostile or conflictual relationship. We can use this in many ways. We can use this in many colors, so that to make our family genogram easy to understand, so that we don't have to have detailed explanation or detailed write-ups on the family overview. We can have only this structure, family genogram, to denote what are all the persons involved, or what are all the systems involved in a family. Violence shows again, which shows violent behavior between family, between a person who can be a financier, who can be her children, a child, or who can be her husband. So this violent relationship that shows that from the first point itself, we could understand that she has a violent, stressful relationship with this particular person. So we can work with that in that way. Or who was a good friend of her, who's very intimate to her, very close to her. We can work with them as well. We can seek their support more for continuing their treatment. These are shown in blue, which is first one is emotional abuse. one individual is emotionally abusing another individual. So we could understand that in the family, who's emotionally abusing her? Is there any sexual abuse? We can have two zigzag lines in blues. And then shows the neglect or a kind of abuse. This arrow shows the energy towards the male person is abusing the female person. So these lines in blue can be struck as the emotional disturbances or sexual abuse or the other kind of abuses in the family. This can anyone of you explain what it is from the genogram symbols that we explained? Can anyone of you say what it is and what is the family bonding? What are all the family, who are all the family members involved? Can anyone of you say? Is it clear to everyone? The family genogram, we can see that there are red dotted lines and plain lines. We haven't used much colors here. So can anyone of you say that what it is?
So it looks like Mrs. A's parents have passed away. She has two brothers who have also passed away. She's got one living sister and a niece and nephew. And she has four children. And it looks like the red dotted lines, I think, means she has kind of a hostile or dysfunctional relationship with her children. So, oh no, so she has, is her husband also passed away?
Yes, yes, yes.
Okay, so yeah, that's what I can get out of this diagram.
Okay, can anyone else can have a detailed assessment on this? Anyone else? Okay, so I'll just explain. The parents of the family are no more. As we didn't have this cross symbol earlier in our symbolic representation. We didn't explain about it. It might be confusing. But I think all are using these kind of genogram in our setting. I believe so. And at a time of your degree or at a time of your education, you might have come across with all these symbols, I think. So first one is the parents, both are passed away, and which is how it is in cross. And the immediate family is a boy child and a girl child. And Mr. B is the boy who's no more, who is also dead. He was married to a 61, he was married to a person who is at the age of 61 now. And Mr. B has a girl child, that is Ms. E. And she is also married to Mr. E, Mr. J, whatever. And he is a mercer. We can have this occupation as well in this genogram, so that we could know that whether they are employed or not, whether they could bear a treatment, whether they are financially well enough to support their family. So this person is a mason. That occupation is written there, so it is easy for us to understand if there are employed members in the family. And they have a boy child who's 18 years now. And Mr. B's sister is Mrs. A, and she is our patient. She is our patient. To denote that, we have the striped lines to show that she's ill and she is our patient. And she was married to Mr. A, and he is no more. She has two kids, two children, and the elder one is a boy who's now 36 years, and he is a driver. He is married to C. She is of 33 years now, and they have a girl child who's of 11 years now. We can have her have the education, which standard she's trying. We can have that education level as well in this genogram. And Mr. C's sister is Mrs. D. She's 32 years now, and she is married to Mr. D again, and he is also a mason, and they have no children. The patient is circled. The circle we use in this palliative care setting to show that who are all there in the family. I mean, she might have all these people. She has her sister-in-law. She has her brother's daughter or their family, but she is living alone. The circle shows that she is living alone. She has no one staying with her. The circle shows that she is living alone. She has no other person to support her in the family by living with her. And she has a stressful relationship with her children and with her sister-in-law. So from this picture itself, we can identify that she doesn't have any support system from any of the family members. Is it clear to everyone? Is it clear?
Yes, ma'am.
Yes. Thank you. Then we'll go to the echo map. Why we need an echo map? This is a pictorial representation, of course, which helps to visualize social and personal relationship of individuals with the environment and with the larger society, which is a definition from Anne Hartman. To show that what are all the supporting systems she has, whether a shopkeeper helping her, we can have that shop name, we can have just like a shop that supports her, or whether she has a church or a temple that helps her by bringing food or by visiting her. So we can have that in the echo map. Or whether the extended family members, relatives, or her neighbors, or any of the friends, or any of the employers, or anyone in the society who's giving a support to her. So we can have this in the echo map. Here we can see that there is a health service person helping her. It's a normal relationship. It shows the normal relationship. We can have this stressful relationship as well. I mean, as we saw that blue lines and red lines, those zigzag lines and green lines, we can use those lines for representing the relationship between these people. Whether she has a stressful relationship with the neighbors. These are the persons might be a supporting system or stressful relationship, a stressful situation that goes into the particular person. It might be neighbors, a relationship from workplace, government service. Of course, we have a certain palliative care services, clinics, or primary health centers near to us. by the governments, whether they are supporting or not. Then the community service or religious institutions that helps or that who can support the family, or whether they have some friends, any clubs, any schools, or any volunteers. So we can have a picture of everyone. Those can be a supporting, or those can offer a service to the family. We can have this assessment to see how to utilize these supports, or how to channelize, or how to find out the resources to support the patient. See here, she has that energy shows from church towards the patient. It is a normal relationship. And from the public health center, she gets a support. From the palliative care, it's also she has a support. And from panchayat, it's just a normal relationship. But from the neighbors, she has a stressful, not that normal, but not that close. A kind of support or a kind of touch she has with the neighbors. Then we can see the socio-economic overview. Who's the breadwinner? Who's the primary breadwinner of the family? Whether he has any illness, whether he is able to help the family, or whether he is able to help the treatment, or he can look after the education or of their children. So who's the breadwinner of the family? And the decision from breadwinner is the most important factor. So we must have that. Then whether they have adequate food, because food, shelter is the basic primary this we must have in a family to run in a smooth way. So whether they have adequate food, clothing, and shelter, these parts are important to know. And other sources of income, whether they have any pension, or whether they get any other support, income generated from any other sources. What is the community support in government schemes, whether they've enrolled. If in Kerala, we have a cancer pension, whether a cancer person has got this facility, whether they have applied for this or not. So these availing these schemes, whether they have availed or not, is important to identify, because they are getting a kind of a small income to the family. Or it might be other supports. And what kind of ration card they have. Ration card is like government supplies. What are all the ration supplies they get? Whether they have any debts. Because debts are the most crucial part to stop the treatment. So whether they have a debts or not. And other financial vulnerabilities. If they have any, have to see the education of their children, or whether they have any other possible vulnerabilities in future in the part of finance. We have to have all this information in the file. Then comes to the psychological overview. Knowing this psychological overview will help us to have psychological support. In a multidisciplinary team, we'll be having our psychologists or medical and psychiatric specialized social workers to help in this area. So whether they have any psychological distress, emotional support they needed or not, anticipatory grief, whether they are grieving, whether they need sessions to grieve, or whether they have to have a coping mechanism to a particular stress. Are they in depression? Are they anxious towards the illness, towards future? So knowing these parts will help us to draw psychological support towards the patient and the family. Then the spiritual overview. Connection. Connection means between people, between the supporting system, what it is, how it is, whether they have a meaning of life. Some people might say that I have nothing. I am nothing. I have nothing, so I am nothing. I am ill, so I can't do anything. So there is no meaning in my life. Are they in that situation? We need to identify it. And strength and comfort. What are their strengths? Are they comfortable? Are they comfort with the persons nearby? So what is the overview? What is the family could say about it, or what the patient could say about it? Are they hopeful? Are they having a question like, why me? Why I am getting this illness? Why God has given this kind of illness to, uh, I mean, to my family or to me? Why I am like this? So these kind of questions can be answered from the person, from the patient, from the family, to have this detailed spiritual overview. Do we have any important areas that to be assessed from the point of view of total pain? Like anything that is related to the assessment? Is there anything to be explained further? Are you all clear with the assessment patterns, assessment points? Or there anything needs to be explained more? So earlier we had a case. So we are coming back to that. If you are clear with all the aspects of assessment, we can go with the discussion related to this case. As I said, please be clear that she is a 56 years of year of lady, and she is diagnosed with the CA breast in 2016. She had undergone mastectomy, and she was referred for pain management. She was looking very anxious. She has no idea about palliative care, and she has some other illnesses as well. She was diabetic. She has coronary artery disease, and she had a fracture after a fall in 2019. And she is a widow. She has her children, but they have a hostile relationship towards her, and she lives alone in her house. So by keeping this person in mind, we can have a discussion of total pain. So what are all the what are all the factors that comes under physical pain? By keeping her in mind, she might be having physical pain. She is fatigued. She has lack of sleep. She has difficulty in walking, and body image issue, disfigurement. So she has these many issues addressed under physical pain. Physical pain must be managed. By underlining all these points, the medical team have a deep look into her physical pain to make her leave, to make her comfortable. Lack of sleep, difficulty in walking, body image issue. Those who have done tracheostomy or by seeing a tracheostomy, it might be very stressful scene. Like by having this, we might feel like we cannot go near to that person. That she might be in a situation that she cannot show her. She doesn't want to show her face to anyone outside. So she might be isolated, a disfigurement. A point of time, she might be a beauty in her society. But after having the operations or after having these ostomies, she might not be able to move out from her house. She doesn't want to show her face out to anyone in the society. So body image issue is a physical pain. And the family members might not want her to come out. They might be ashamed by showing her out. Difficulty in walking. So these are the physical pains that our person experience. And the psychological part. She's isolated. She's emotionally weak. She is anxious about future. She's not aware of or unclear about. She's aware but not clear about prognosis and palliative care. She doesn't know. She said she doesn't know anything. She doesn't know what to do in future. She doesn't know. Might be doctors might be saying that your treatment is over. There, you can have these pills, or you doesn't have anything else to do. But she has pain. So she doesn't know where to go and what to do. So by knowing these factors, we can explain to her. We can explain her prognosis. We can explain what is palliative care services. And she can have a good pain management later. Then distress due to multiple illness. She might be distressed. By knowing the psychological factor in this area, we might help her with a psychologist. We can have sessions and sessions to help her out from the distress. So these are the points that our patient is experiencing. Then comes the socio-economic part. She has a strained relationship with her family. So that is noted there. Unable to go for job. So she has no income to the family to live on. That affect her food, shelter, clothing, medicines, everything. Financial instability. She doesn't have anything. House rent. She might be in rental house. So who will pay the rent? If she doesn't have any income towards her family, towards her house, how will she pay her rent? Her children are not supported. Low accessibility to hospital. We saw that the path that leading towards her house. She might not be able to walk along. Any travel facility can't reach to her. She doesn't have proper paths to have a vehicle reaching her house. So low accessibility. Absence of caregiver and support system. She doesn't have any support system. Doesn't have any caregiver. She's not in a situation to hire a caregiver. So she doesn't have any kind of support system to improve from the illness or from the disease, from the illness that she faces, that total pain she's suffering. And in spiritual, she has extreme spiritual distress. She's saying that why all these sufferings, why are she suffering all this? Why she has done, why God has done all these things to me? She can't have any memorable or joyful events in life. She can't have any birthdays, any anniversaries that she could celebrate. There is no one to support her, and she's in a lying situation. Or she's bedbound, she's wheelchair bound. There is no one to, there is no way to go out and to have her and to cherish her activities, even to step out from her house. She's these are the factors that comes under spiritual pain. No significant person in life. There is no one to contact. There is no one to grieve or to depend on, to smile on, to speak on, to cry towards. Nothing. Nobody is there in her house to be with her, to feed her, and loss of connection with the family. She might be thinking that if her sister-in-law, she could come and meet her. If her children, if she wants to see her grandchildren, these all connections are being blocked. She's limited towards all the family connections and lost faith in God. So she doesn't have faith, or she doesn't have any memorable, joyful moments in her family. She doesn't have anyone in her family to look. So these are all the total pain she's suffering through. It is very important to have all these assessments. Then only our palliative care service we can have a set of goals to continue our palliative care service for that person. If we are not knowing all these aspects, we cannot work, because physical or clinical interventions are not the only part to improve a person. We need psychological support, socio-economic support, and spiritual support as well. Why do we have interventions? We have collected all these assessments. We have collected all this information from the person or from the relatives, from the neighbors. We had all sorts of information in our chart. And then we can have our interventions. We can provide information. We can provide information about ourselves, our palliative care service. We can provide information about the other palliative care services nearby. Or we can provide information about government facility that could reach to her. Certain schemes might be helping her by providing pension, or by providing airbed or other necessities. We can provide information towards her. That is an intervention, a kind of intervention. Liaising with the government. She might have applied for a house modification. We saw that what type of house she has. It is about to fall. So we have certain schemes with the government. So we can liaison with the government to make her avail that scheme. We can have liaising with other NGOs who might be helping her for education, or who might be helping to make her pathway a better one. So liaising with other referral services we have in our country is an intervention. Facilitation, of course, facilitating the service. Rehabilitation. Whether she could have a rehabilitation support, because she's living alone. She has nobody to support her. Whether we could have a vocational rehabilitation, we can have some certain kind of, if she's improved in her physical situation, she can have certain vocational rehab. So we can have certain training. We can make her, we can use her hands. We can, with the support of a therapist, we could, physiotherapist or occupational therapist, we could know that what kind of rehabilitation support we can provide to her to be on her own feet. Follow-up of all these interventions. Follow-up is a one-time support is not enough. We all know that. So a follow-up, a continuous follow-up, whether she needs follow-up in a month or in 2 months or in 3 months, we have to have a goal for the follow-up, and we should follow her up. And supportive counseling and psychoeducation. These can be from the social worker, from the psychologist. These could help her to grieve, or these counseling sessions will help her to have a role in herself. And later, bereavement support. Our support is not limited with the end of the life. A doctor's intervention might be limited with might be closed with the end of the life of that person. But a palliative care service doesn't finish with her life. It is extended after her death. That is called bereavement support. We can have bereavement support in many ways. We can provide education. We can give job to someone in her family. So how the family is undergoing all this situation after the bereavement, and we can have a support based on that. So a bereavement visit or visiting the family after her death might help us to know what are all the bereavement supports we can have to that family. These are some possible social impact, like social isolation, dependency, financial instability, lack of social support, death, loss of work, interpersonal issues, inadequate facilities. We can facilitate these as well. These are some social impact. Possible psychological impact, mostly feelings of shock, uncertainty, hopelessness. This is a detailed version of some psychological impacts that might cause a person's family. Vulnerable population. What are we called as vulnerable population? In our assessment, we can have this vulnerability, whether they have moderate, severe, or moderate vulnerable situation, whether they are living, which is coined on the basis of these points, whether they are living alone, whether they are supported with an elderly person, whether they are single parent. Multiple patients in the family can also be a vulnerable part. Victims of gender issues, individuals with mental health issues, individuals with the suicidal ideation, socially isolated, substance users in the family, individuals in extreme poverty. And these are some points that make us to derive their vulnerable status, whether they're mild, moderate, or severe. Then last, but the most important part in a patient life is their caregiver. Definitely, we need a caregiver to support her till her death. There are, as per the Rocklin Carters, there are only 4 kind of people in the world, that are those who have been caregivers. They were being caregivers, and those who are currently caregivers, those who will be caregivers, and those who will need a caregiver. So this is from Rosalind Carter, like type of caregivers that we could see in our daily life with the patient, and respect those individuals and acknowledge their complex role. They are doing the complex role in their family, and most of the time they are the invisible patients in their family. So respect caregivers. Their role is not just a bystander. We at times we coin them as bystanders, but they are not bystanders. They are doing everything for the patient. They are the caregiver. So these are some pictures that before before an end of life, we help one of the patient to celebrate her anniversary. A beautiful moment before they pass, like birthdays. They might be wanted to celebrate their birthdays. So by knowing their wishes before their end, if we could have these kind of activities, that could be a support for the family, and that could be a good death for the person. And some vocational rehabilitation that we provide to stabilize the family's income. We can have these kind of vocational rehabilitation for the person or for the family. We can provide them with whatever they want, or what are all the areas they are trained, or what are all they can do. By analyzing all this, but we can provide these kind of vocational rehabilitation to generate an income towards the family. And social support. As part of social support, we provide education support, food kits, vocational rehabilitation, and travel aid, physical aids. All these supports we provide as part of palliative care. This is a support for children that we have. A group of people, a group of children who share their emotional, educational values with others, with the peer group. We have a coined term for this. We coined it as Kutikutam. We have this children once in a year or once in 6 months. We have a meeting with her. We have a good group of volunteers as their mentors to support in their future, to give them proper guidance. And please do remember that we need to evaluate our interventions, whether we are doing the perfect one, whether we are doing the right one towards the family. We need to evaluate it. Assess how the patient and families are benefited, whether they are benefited or not. If you are providing the vocational rehabilitation, whether it is useful for the family to run. Assessments have to be revised and updated. Their need might get more in future. So we need to update it. We need to revise it. We need to reassess it, whether they need it or not. Reach out for help if need. Whatever the need is, please be there on call. There is an art and science in psychosocial care, just as medicine. It's not only medicine that that is a support in palliative care. We have to have psychosocial care as well. So by this, the difference between what you do and what you are capable of doing will solve most of the world's problems. It's been said by Mahatma Gandhi. He is the Mahatma, and he said what we are doing, it must be to solve the problems. So we have to have these kind of assessments, psychosocial assessments, emotional assessments, spiritual assessments, all aspects of assessments to understand the situation of the patient and the family. Then only we could have proper palliative care system. We can have a good support. We can provide a good support to the patient. So by this, I think we can wind up the session and we can have
Okay, thank you, Deepa, for the wonderful session. I think we can go on to the case presentation. Time up, we have only 10 minutes. Ranjita is ready for presenting a patient story. Ranjita, over to you. In the meantime, if you have any questions, please put it in the chat box. After that, we will discuss. Ranjita, are you there? Please unmute yourself and talk. Ranjita, can you hear us? And then you have to, you can just listen their worries, and then you can think whatever you can. And also his children's. I don't know how their studies are going well or not. So because of his problem, that children's studies, the education is also might be affected. So that aspects also you have to think about. So, anything you want to add, Deepa?
They should have a good supporting system. We can work on that. And his vocal cord is affected. So he might be facing difficulty to face the society. So a sensitization part with the society is also essential. So those awareness in the community that needs palliative care better than we work alone, because the community will support him. So proper counseling sessions and supportive system and palliative care in all aspects will improve the condition of that patient.
So, and also before he was a good singer. Now, because of his illness, his voice is not good. He is not able to sing properly. Because due to this, his will be like spiritual pain is also there. Why God punished me like this? This kind of spiritual pain will be there. You have to listen and try to. Sometimes physiotherapy will be helpful for the patients. Try to include physiotherapy and speech therapy like that. So you can add some. Think about the occasional rehabilitation. One as one of you said before. These kind of rehabilitation things you have to physical rehabilitations you can think about that. So then we can try to back to his normal life, because not in fully a normal as earlier stage, but we can as much as possible we can try to as a normal person, because now he is having hemiparesis. If you give a proper physiotherapy and training for to him, definitely we can improve his quality of life. And also we have to think about his mother also. His mother is old age. He is look after him. So we need to think about his mother also. We have to listen her worries also, because she needs to explore her worries. Her daughter-in-law and the grandchildren left him because of this. The mother is also affecting a lot. So you have to listen her worries also. Okay. Any doubts?
There is one.
One chat. Any other questions? So I think no more questions. Anyway, we have a detailed the session today. I hope you all understand about the psychosocial issues and how it is important for in the daily the patient's life, and psychosocial aspects will be affecting the patients more, and the physical distress is also increasing more if they have a psychosocial spiritual issues there. We need to address them properly and try to make them as much as make them comfortable as much as we can. So that way definitely we can improve. If you give a proper attention to all aspects like physical, psychosocial, spiritual, and emotional aspects, there definitely we can improve the quality of life of the patients. As the patients, we hear the patient story, that patient is also affecting this affecting with the more issues, because he has some physical problems, but along with that he has lot of psychosocial issues. Definitely we need to address them. Then only we can improve the quality of life of the patient and the family. Okay. Thank you, Deepa, for the wonderful session. Thank you all for joining in, and thank you for your that cooperation and your contributions. Thank you. We'll see you next time. Thank you.